warm welcome for you to join International Mental Health Virtual Conference under the topic Mental Health Challenges, Stress, Depression, Burnout, Suicide, Situation and Management. First of all, I would like to introduce Dr. Thursak, Director of Bureau of Mental Health Academic Affairs, to express attitude, organization that work together.
Thank you and good morning and good afternoon to everybody. I would like to, before the webinar start, I would like to say something, and as a behalf of the Mental Health Department of Thailand, this webinar cannot be settled without the working together of organization. So I would like to thank you and express our deep gratitude to our organization, Department of Mental Health, our DG, Dr. Panpimon Vipulakon, the English Embassy, and Prosperity Fund of England, and also the speaker that come to join today to share the information and knowledge, and also including the participant from Thai and international participant. So I think that I would like to say thank you, and I hope that the information that we share today will benefit to all, everyone that work in the field of mental health. Thank you so much.
Thank you, Dr. Thursak, for grateful welcome and speech for all participants. Okay, let's start. Due to the global impact of COVID-19 has been profound, and the public health threat is the most serious. Overall, the pandemic will have an impact in all domains of the current world, starting from health, society, and economy. It would also impact future policy making at the global, regional, and country levels. The COVID-19 pandemic has not only a physical health crisis, but also has the potential of a major mental health crisis. The long-term pandemic will affect the economy, contributing greatly to stress, anxiety, burnout, and illness with mental health disorders. Moreover, the impact of crisis leads to attempted suicide. Therefore, in order to reduce the impact on mental health problems, namely stress, burnout, depression, and suicide, we will have to support people and health personnel in their knowledge of self-care. We are aware of the mental health impacts. So, Department of Mental Health Thailand collaborate with Embassy of the United Kingdom to develop 3 webinars. The title of the webinars, our first one today, is Mental Health Challenges, Stress, Depression, Burnout, Suicide Situation, and Management. The second title is Digital Mental Health Service, Tool for Improving Service Quality. And the last one is Building Up Nations' Resilience. On this occasion, I would like to introduce Dr. Christopher Asiter as the moderator of the section, who is the Better Health Programs NHS advisor in the United Kingdom.
Thank you very much for the introduction, Dr. Sankaman, and good afternoon, everybody. Just to reiterate, welcome to this first webinar that we are hosting, the British Embassy in Bangkok is hosting with the Department of Mental Health in Thailand. And I think it's very interesting to see the number and range of countries represented on this webinar today, which shows the importance of this issue. No longer can mental health be seen as kind of the third disease after sort of communicable and non-communicable diseases. As Dr. Sankaman said, my name is Christopher Exeter. I'm the NHS lead for the Better Health Programme based at the UK's Department of International Trade and NHS England in London. And the Better Health Programme, just by way of introduction, is one of 12 programmes in the UK's Prosperity Fund. We cover 8 countries, 5 of which are in Southeast Asia, many of which are on the webinar today. And the aim of the programme is to build a set of collaborations and partnerships between the United Kingdom and our partner countries in the programme to help strengthen health systems, but also importantly to share experiences. And I think this is a good example of that, how we learn from each other, particularly not just in a time of crisis, but actually how we manage and develop health systems for the better health outcomes for the people that we serve. We are delighted to be working in partnership with the Department of Mental Health, and this follows the very successful webinar that we worked together on back in August. Just in terms of a few housekeeping rules, which I've been asked to outline. Can you just ensure you keep your camera off when you're not speaking, please? Microphones should be muted, but if you could just make sure that's in place. Online participants can submit their questions during the course of the session on the chat bar, and we'll come to those at the very end. And on-site participants will be asking their questions live at the end of the 3 presentations that we're going to hear this morning. And as a reminder, this event is being recorded. There's a slight change to the order of the presentations today. We're going to start with Dr. Haslina, who is the Deputy Medical Director of the Hospital Kanai in Malaysia, who's going to talk to us about behind every hardworking frontliner. So, Dr. Haslina, over to you.
Thank you very much, Dr. Christopher Exeter. Can I have slides? Is it possible for me to view my slides? All right, okay, fine. Okay, so thank you very much. Good afternoon to Dr. Campion, Dr. Burin, to all participants, and thank you to the Department of Public Health Thailand for inviting me to speak on mental health issues related to COVID-19 pandemic. It's been a pleasure. So as we can see, okay, do I say next to change the next slide? All right, thank you, all right. Okay, so by the way, this is the first time I'm doing webinar, so it's a new experience for me. So anyway, so as you can see here on the slide, you can see that our beloved planet is not doing too well these days. You know, we've been living with COVID-19 for the last 10 months, and it has been a tough uphill battle for all, including the healthcare workers. I remember about 30 years ago, our former Prime Minister had a vision for Malaysia, which he coined Vision 2020. So there was Vision 2020 had 9 challenges. So one of them is being a developed society. So basically, Malaysia is still working on that to overcome these challenges. However, I did not think that the former Prime Minister, Tun Mahathir, thought that pandemic, COVID-19 would happen in 2020. All right, next. Okay, so basically this is the content of my lecture today. I'm going to talk about COVID-19, the Permai story. That's where I work, Hospital Permai. I'll tell you later what is Hospital Permai. I'm going to talk, actually, initially I thought of presenting a preliminary data from a local study, but I actually, I did not submit I need to get approval from the Director General of Ministry of Health, but I forgot to do that, overlooked that, so I couldn't present that today. I will be talking a bit about the challenges of facing an unprecedented event and what we have learned so far. All right, next. Okay, basically, Permai, let me tell you about Permai next. Okay, so basically this is Hospital Permai. This is where I work. These are the buildings. The picture on the top left is the administrative building. The one on the right is the quarters where Hospital Permai accommodate their staff. The one on the left and right, bottom left and right, those are the wards. Okay, so it's a rather new building. It was completed in 2012. It was to replace the old Hospital Permai, which was built in 1937. So this is a rather new building with a lot of new facilities. Okay, next. So basically, Hospital Permai is one out of 4 psychiatric institutions under the Ministry of Health Malaysia. We occupy about 151 acres of land, in which we have a total of 1,132 beds. The bed occupancy rate is rather low, about 59%, and we have about 12 complexes, among which we have an acute ward, a long stay ward, a forensic ward, outpatients clinic, occupational therapy complex, and an administrative building. Okay, next. So basically, Hospital Permai, in response to the increasing number of patients due to the pandemic, Hospital Permai was made a hybrid hospital for COVID-19. This is to help to manage the patient under investigation for COVID, as well as patient who was under surveillance. So a hybrid hospital basically means that we provide care for not only COVID patient, but also the psychiatric patient. So we have both service under one roof. Hospital Permai has been designed to provide care for isolation center previously for other infectious disease. You know, we've had outbreaks during MERS-CoV, Ebola, as well as dengue. So we do have a dedicated ward which has isolation rooms as well as labs. So we are rather prepared to accommodate outbreaks. So basically, when we became a hybrid hospital, it means that we have 2 administrative within one hospital. We have 2 heads. So we have a head which is the director of Hospital Permai, looking after the psychiatric services mainly, and we have the infectious disease specialist who came from another hospital nearby, a general hospital, Hospital Sultanah Aminah, who look mainly after patients with COVID-19. So we need to work hand in hand together. So basically, all these were coordinated by the State Health Department, the Director of State Health Department. So the State Health Department played an important role in coordinating a lot of things, such as mobilization of staff from all over districts within within Johor itself, and ensuring that the welfare of patients and staff are well looked after, and distributing the medical appliances accordingly. Can we have the next slide, please? Okay, basically, we know this is what happened, okay, during the outbreak. Okay, what happened on the 31st of December 2019, WHO received a notification cluster saying that there's a cluster of pneumonia of unknown origin, followed by the 30th, on the 30th of January 2020, the DG of WHO announced that it is a public health emergency of international concern. Followed by the 23rd of January 2020, the first 4 imported cases COVID-19 arrived in Malaysia, and that 4 imported cases arrived in Johor, and they were admitted to hospital Burnout. Followed by 11th February 2020, COVID-19 was declared an epidemic, and later on it was declared a pandemic. So basically, the National Security Council in Malaysia was activated, and the NSC Directive number 20 was also activated. It states that there is need of mental health and psychosocial support in disaster management. All right. All right. So basically, there's a lot of coordination that needs to be done. Okay. So we need to work with a lot of agencies. Can we have the next slide, please? Okay, so in Burma itself, as I mentioned before, on the 23rd of January 2020, we had the first 4 imported cases admitted to Hospital Burma. 3 days after that, the mental health psychosocial support team operations room in Hospital Burma was activated, and this is to provide mental and emotional support for staffs. And later on, the 11th of February, the State CPRC and Disaster Management Committee was activated. Okay, so basically, the mental health, the well-being of is very important. Mental health well-being for the healthcare workers is of importance. Okay, can we have the next slide, please? All right. So basically, as I said, it was activated. Okay, it was activated during the first wave, and then now the second wave. So the focus mainly for the MHPSS is primarily we want to look into the mental health and well-being, wellness and resiliency of healthcare workers involved directly or indirectly managing patients with COVID or patients with under surveillance or patient under investigation. So that's the primary focus for MHPSS. The secondary one was we want to look into the mental health and wellness of patients with COVID or patients who are under surveillance or under investigations. So basically, we know that, COVID-19, healthcare workers, when they deal with the situation of COVID-19, looking after patients with COVID-19, it is highly stressful, it is exhausting, because there's sudden surge of cases, it's unpredictable. So there's rapid changes in various situations, the number of patients as well as policy. Guidelines keep changing. I think now it's the 6th guideline for the management of COVID-19. So imagine it happens within a short time, from February up until now, over 10 months, okay? So instructions keep changing rapidly. So there's a lot of unpredictability. So we need to live with this new norm, okay? There's a lot of adjustments that needs to be done. And this adjustment need to be looked into within a short time. So the healthcare workers, they need to, the workload, there's issues of workload. They have to withstand very uncomfortable environment. They have to wear PPEs for long hours, 5 to 6 hours. So it's challenging. Malaysia is a hot country. So imagine having 2 layers of PPEs that you have to wear over 6 hours. So in the end of the day, they are drenched wet. So it's very exhausting. So at the same time, you have to remember healthcare workers, they have their own families, and that's another concern for them. They have to look into work-life balance. They have to think about childcare, because during COVID-19, movement control order is implemented. So during this time, a lot of childcare centers are closed down, the schools are closed down. So the issue of who to look after their children. So they have to think of how to balance it, how to balance this issue, who to look after their children, and they have to look after themselves as well. Okay, so and then on top of it, if they have ongoing emotional baggage, so they have to look into that as well. So a lot of things that they need to juggle. Additional stress, they also have their own fear, the stigma of the fear of getting infected as well. So those are the concerns. So therefore, in Ministry of Health Malaysia, we stress the importance of the mental health psychosocial support services. Yeah? So it has to be done in all states, in all districts, all hospitals. All the hospitals in Malaysia, all districts are involved. Okay, and everything is coordinated by each states, nationwide, from top down. Okay, all right. So next, please. Okay, so MHPSS team, they have a lot of things that they need to look into. These are the things that they need to look into. They need to identify. So basically, we have to think about it like the mental health psychosocial team. They consist of multidisciplinary. It's a multidisciplinary team. So it consists of a psychiatrist, more than one psychiatrist, clinical psychologists, paramedics. Sometimes they do get help from the NGOs. These are the team on the whole will provide psychological support to target groups. As I mentioned, the target groups are the patients under investigation, under surveillance, as well as the healthcare workers themselves. All right. So basically, they will provide. So the MHPSS will provide first psychological first aid, in individual or group sessions. So they need to identify the needs. Okay, what are the needs? During the sessions, they can identify the needs. Okay, but the thing is, the way we do it, it's different. We cannot have a face-to-face session because of the nature of the infectivity of the disease. So a lot of the time when we reach out to the healthcare workers, to the patients, we will do it, we do it through telephone line or so the other forms of communication, WhatsApp, messaging system. All right, so that's how we try to identify the needs. Okay, I will show you, that we give out posters, to tell them that we do have a counseling line which they can contact, mainly during office hours. What numbers to contact, and we are available during this time to talk. Okay, so they can contact the telecounseling number. All right, so we need to support them psychologically, physically. Okay, look into their needs, food, ask whether there's enough food or drinks, other things, general welfare, those are the things that we need to look into. Okay, and also it is important that we provide the necessary information. Okay, so a lot of the time we need to we used social medias, WhatsApp group, telegrams. Those are very important tools. Okay, so information is very important. Dissemination of information. Okay, we also we need to prepare them. Okay, for any task. So basically, a lot of staff that are being deployed from all over the districts, from other hospitals to the full COVID hospital or the hybrid COVID hospital. So they have to travel from far away, many kilometers away, and they have to leave their own family members. Okay, so there's a lot of adjustments. So a lot of them, they need to go through pre-deployment counseling to see whether they are suitable to be deployed to the COVID wards. Okay. So there's a lot of issues that we need to look into. So it's quite a complex task, really. So a lot of the things we cannot do it alone. You know, our own mental health or MHPSS, we only have 30 staff, and they still have to look into their own tasks. You know, they have their own work that they have to look into. You know, they still need to see psychiatric patient, but at the same time they still need to support the healthcare workers as well as the patients in the COVID ward. So a lot of juggling that they have to look into as well. So they need help from other collaborating agencies as well, such as NGOs. All right, next slide, please. Okay, so basically I mentioned that we cannot do it alone. We collaborated with the state MHPSS and as well as other MHPSS in the hospitals and district offices to lead a better workflow. And as well as we do get updates from them as well. You know, that is helpful. All right, next slide. Okay, so this is it's not that clear, sorry about that. But this is the flow chart for the mental health psychosocial support intervention flow. So basically, there's an assessment for an early detection done. And then we'll provide the psychosocial or psychological first aid intervention. And then if there is need for a referral, then we will refer to psychological intervention. If they are well, then we'll discharge. But if there are signs of psychiatric illness, then we'll refer to psychiatric services and they will have follow-up. If none, basically, we will discharge them, as simple as that. Okay, thank you. Next, please. Okay, so basically this is one of the sessions where we provided the counseling or pre-deployment or sessions that we have in Hospital Permai. Okay, all right. Next. Okay, so basically there's a lot of challenges, as I mentioned before. Okay, there's a lot of challenges facing this unprecedented event. Next. Okay, so a lot of the challenges is because of the there's a lot of rapid change of instruction, as I mentioned before. Changes happen within a few minutes or a few hours, a few days. So we need to keep ourselves updated with the changes. You know, the number of cases will rise suddenly in one area and then in the other area. So instructions of movement control orders changes. So we will have, if there is a rise of cases in one area, then that rise of cases will lead to need to control the movement of the of those in that area. So this restriction of movement will give rise to a lot of stress as well. So the rapid changes also happens will also have impact to the staff in the hospital as well. You know, so these rapid changes of instruction, you will need a good leadership to lead. You know? So you need a leader who can give swift instruction, who are aware of what's going on, who gets feedback very often. So they need a daily meeting for the higher management in the hospital, especially in Hospital Permai. And then, of course, the challenges are balancing between mental health needs and work. And then there's also worry of stigma. I see that there are similarity, between psychiatric patients and patients with COVID. There's stigma. COVID, the stigma is the fear of the infection. Psychiatric patient, the fear is that patient will become aggressive. So we have that similarity. So we have to have a lot of reassurances between these two teams. Okay. So for example, when we have psychiatric patient who is in acute relapse, so we need to admit them in the COVID ward. So the priority is the patient having COVID infection. So we need to admit them in the COVID ward. So, but at the same time, we need to support them, the staff in the COVID ward, to manage patient who is acutely in relapse for the psychiatric condition. So those are important. So we also need to assess accurate information. So we need to make sure that the information is clear. So we need to make sure that the source of important information is valid, is accurate. So we need to know who or where we get the information from. Okay. So in Malaysia, we do have Telegrams groups for CPRC and the National Disaster Agency to disseminate information, correct information. They will inform about the daily updates about the number of cases. So that helps in getting accurate information. So other challenges is issues of burnout. We have staff who are being who are deployed from other areas, and then they have to withstand this difficult environment. So they are exposed to burnout, and morale injury. And there are the issues as manpower. They can only work so much during, they can't work on and on for many months in that situation. So we need to look into that issue. Okay, so everything is very dynamic and it moves very fast. Okay, next slide. Can we change the slide, please? All right. So basically, how we disseminate information is that by giving talks on radios. A few of my colleagues, they were invited to talk about mental health issues among healthcare workers on 2 or 3 radio shows, and also they were invited to be interviewed by major newspapers to talk about mental health issues and how to cope with mental health issues. And we also disseminated pamphlets, hard copies, soft copies of pamphlets, right? We also offered helpline for us to offer psychosocial support. We also we prepared a video to demonstrate ways to cope or how to practice relaxation exercise. And then, as I said just now, due to the nature of the disease, it's not feasible or advised to have direct consultation. So we provided teleconsultation through phones. And of course, besides talks on radios, psychiatrists from Hospital Permai has been invited to be interviewed on TV shows, and as well as we disseminated information on the social medias. We have the Facebook, Hospital Permai Facebook, as well as the State Health, Johor Health State Facebook. Okay, all right, next. Okay, so this is the telecounseling, this poster inform about the telecounseling that we offer for the healthcare workers. Okay. WhatsApp group, telegrams. So in order to gain access, they can register using this QR code, and they can contact the number as listed here during office hours. Okay. So it's open to everybody who needs to talk. Okay, and this one is a poster of my colleague, Dr. Rahida. She's a child and adolescent psychiatrist. She was invited to give a talk on challenges of parenting during this pandemic. Having children at home for most of the times. And then need to monitor their studies and all that. So it's a challenge on how to do that. This is a picture of some of my staff who went to the center which provided, they had to take swabs to a village nearby which had an outbreak of COVID. So they visited healthcare workers, as well as the locals who needed reach out. They reach out for them, if there is need for psychological first aid. Okay, next. All right, so among the things that we provided for the frontliners is this one on the left, is the psychological support kit, COVID-19 for frontliners. So in here we have tips, we give tips on how to cope with stress, and how to practice relaxation exercise, and what to do, how to seek help if they have symptoms of stress. This is a poster of a psychologist, Ms. Hamiza. She was invited to give a talk, to talk about mental health issues among frontliners. And this is my colleague, Dr. Suhaila. She was invited to talk in a radio talk. And she spoke about the psychological impact of COVID-19. And on this far right, this is a video which the staff of Hospital Permai, we came up and it demonstrated how to do relaxation exercise. Okay, all right. So basically, a lot of adjustment, we have to adjust to the new norm. It's not easy, okay? We have lived 10 months with the new norm, so we may need to live with it for the next few months. Next. So basically, what are the lessons learned? Next. A lot. So main thing is communication. It's very essential. How to keep a clear communication, very straight to the point, very clear communication, and then the chain of communication, top down, and to make sure that the information gets disseminated and delivered to the person, everybody. That's a task. Sometimes it can be challenging, even though we live in this era where the technology is high end, but sometimes communication can be an issue as well. So that's very important. Coordination and support in managing crisis. So that's also important, The swiftness in making decision. So leadership is very important in this situation. So we need leaders who very, who give directions or instructions very clearly, and they need to make decisions swiftly in order to help to smoothen the operation. And I find that what I learn myself personally, it develops a lot of resilience within me, as well as I notice among my colleagues and others, who goes through this. We never knew that we had it within us, the strength to go through this very difficult time, Imagine, you a lot of things that you cannot do nowadays, you cannot. meet your friends face to face. You cannot go out and you travel outside the country. So a lot of restrictions. So sometimes you cannot see your own family members who live far apart. So you have to find ways on how to communicate with them and communicate or get in touch with them. The other thing is teamwork. It is very much, we learn a lot, how to work in a team, how to make us more reliable and more supportive of each other. So a lot of things that we need to consider, in order to make the team work effectively. Next. So, and what is important is that the technology, I think a lot of development or we never knew that there's a lot of technology that we can use during this time. I've never thought that I could have this Zoom webinar, right? Of course, we've been using social medias, Facebook, WhatsApp, IG, Telegram. So we never knew that there's a lot of things that we can utilize from this. So I feel that a lot of things has been optimized during this time. And then of course, teleconsultation, who would have thought, we provided teleconsultation for those affected by COVID, as well as in our day-to-day outpatients consultation for our psychiatric patient. We do provide teleconsultation as well. So it teaches us to be more tech savvy. And of course, there's a lot of opportunities for research. For example, we do have papers, that we have submitted, such as this psychosocial effect of COVID-19 amongst healthcare providers in Johor. We're writing it up and we'll be submitting it. And then we are collecting data for prolonged grief disorder among bereaved family members of COVID-19 pandemic in Malaysia, a cohort study. So a lot of opportunities. I'm sure there's a lot more which I'm not aware of happening all over Malaysia, but these are the studies happening in Johor. Okay, I think probably I'm at the end of this. Is there one more slide? Okay, yeah. So basically, this is to show our own Director General, Tan Sri, Dr. Nur Hisham. He worked very hard ever since the outbreak, ever since January itself. He appeared on TV every day in the afternoon. Everybody wait to hear him talk. This picture on the left, he admits, that he's been stressed and he cannot sleep for the past few months. So it's been taxing for him. So us on the right, basically when, knowing that our Director General is feeling very much distressed, our head of psychiatrist, Dr. Salina Aziz, we decided, as a psychiatrist, all over Malaysia, we collected money and we bought flowers, to give to Tan Sri Nur Hisham, Dr. Nur Hisham, as well as his team, who has worked very hard. Okay, and then one of our colleagues, she wrote a nice poem for him. So it received a lot of response. I can remember a few hundred responses from the Facebook followers. So he was very pleased. So these gestures means a lot. All right, next. Next slide, please. All right, so these are the reference. Okay, I think this is my second last slide. I think with that, the last slide. That's it. So basically, this will pass. These two shall pass. We don't know when. Hopefully, as soon as possible, in a few months' time. So we pray hard that everything will turn out all right. Okay. There are reasons why things happen. So we make sure we play our role accordingly and help each other, right, along the way. So with that, terima kasih. Thank you very much. A tagline from Malaysia, kita jaga kita, means we look after each other. Thank you very much.
Thank you very much, Tina. That was a great presentation.
Thank you.
A good ending. This too shall pass.
Yes.
And was excellent to hear about changes needs of the patients with the needs to keep things. So that's. Thank you very much. I'd like to move on now to Dr. Jonathan Campion. Consultant psychiatrist and director. So, Dr. Campion.
Good morning, everyone. Good afternoon, everyone. I'm sorry. Just wanted to check that the audio is okay. Good afternoon, everyone.
Yeah, good afternoon.
Great. I'm delighted to be here today and to be presenting to you on this very important topic. And I think thanks to Dr. Hazelina for a fantastic presentation. I'd just like to start by thanking the organisers of the conference, the Department of Mental Health in Thailand, and particularly particularly Sivakan Sumote, and also at the UK Embassy in Thailand, particularly Ravipa Kongvaronwun, who's been very helpful in organising this conference. So I was going to talk about how we address the public mental health challenge of COVID. And if I could have the next slide, please. Essentially, my talk will outline, first of all, what public mental health is, the impact of mental disorder and well-being across populations, relevant risk and protective factors, and then really focusing on the public mental health impacts of COVID. Talking about interventions to both address mental ill health, but also to prevent it from arising and promote well-being, and then looking at the implementation gap even before COVID. And then I guess how to address that intervention gap, which has been made even greater by COVID. Next slide, please. So essentially, public mental health is a population approach. And obviously, as psychiatrists and mental health professionals, we're seeing patients, individual patients, usually sometimes in groups, but it's taking a population approach to the implementation of different types of intervention provided by different sectors. And essentially those interventions are split into these four groups: treatment, the prevention of associated impacts of mental disorder, the prevention of mental disorder from arising in the first place, and the promotion of well-being. And the aim is to sustainably reduce the impact of mental disorder and promote mental well-being across populations. Next slide, please. So essentially, in terms of evidence, this is really, I suppose, critical. And I was at the Department of Health in the UK for several years. And what really struck me there was the importance of having the best available evidence to make decisions. And I suppose as practitioners, we're also looking at the best available evidence, usually in guidelines. And we're looking at different levels of evidence. And I think if we're looking at policy and making decisions, we want to ideally be looking at the highest level of evidence available. And for this presentation, I'll be sort of highlighting meta-analysis or systematic review level evidence. And just like to direct you to a report which I did last year, which was produced by the Royal Society of Public Health, which essentially summarizes all this evidence. Next slide, please. So first of all, looking at the impacts of mental disorder and well-being. Next slide, please. So even before COVID, when we look at WHO's global burden of disease study, you can see that it's a fifth of disease burden globally is due to mental disorder and self-harm. And interestingly, it's almost half of disease burden amongst 10 to 24-year-olds. And then you can see it's roughly similar in Thailand, Malaysia, a little bit higher in the UK, but we're looking at similar proportion of disease burden. But these figures actually underestimate true burden by at least a third. So again, we can see this huge impact across population health. And furthermore, the proportion of burden is increasing. And this comes at a huge economic cost. Again, even before COVID, we're looking at $2.5 trillion US dollars, which is projected to increase to over $6 trillion US dollars by 2030. Next slide, please. And there are several reasons for the size of the impact of mental disorder, as I've highlighted here. And I'll just go through each of these in turn. So the next slide, please. The majority of lifetime mental disorder arises before adulthood. So half of lifetime mental disorder has arisen by the age of 14, 75% by the mid-20s. And this is several decades before physical illness. And actually, mental disorder is a risk factor for developing physical illness later. And obviously, this has very large implications for the age of implementation that we're thinking about for when we're actually implementing interventions across the life course. Next slide, please. The second reason for this large impact is the high prevalence of mental disorder. So in the UK, each year, at least almost a quarter of adults experience at least one mental disorder. And I was looking at some of the data from Thailand, and certainly you can see here the data from an excellent study by Dr. Punapar done published in 2017. And then again, you can see figures slightly higher in Malaysia. And there's reasons for the difference in prevalence rates, but obviously some of it's related to how we measure. Importantly, though, there's an even larger proportion of the population experiencing sub-threshold mental disorder. So they've got some symptoms, but that has impact on well-being and is also a risk factor for then going on to develop mental disorder. Next slide, please. And the third reason is the very broad impacts of mental disorder. So during childhood and adolescence, there are health-related impacts, including physical illness, both communicable and non-communicable, self-harm, suicide, a range of different health risk behaviours, and premature mortality, even during childhood and adolescence. And then a broader set of impacts on education, educational outcomes, behaviour, offending, and social skills. And then mental disorder arising during childhood and adolescence has impacts in adulthood. So if you develop a mental disorder during childhood and adolescence, you've got a threefold increased rate of having a mental disorder during adulthood. And as well as that, a broader range of impacts if you develop a childhood mental disorder, then impacts across adulthood that I've highlighted there. Next slide, please. This slide is from the last National Psychiatric Morbidity Survey done in England, which was published in 2018. And I've just really sort of highlighted the impacts across a range of health risk behaviours on the left there. And then if you have, as an 11 to 16-year-old, if you have emotional or behavioural disorder. And you can see the huge impact in terms of smoking, drinking. One of the focuses of this event today was also self-harm. And again, you can see that the impact of mental disorder across these different areas is huge. And again, this should be actually very important to our public health colleagues. Next slide, please. And then in adulthood, of course, there are a range of impacts. So health-related impacts, importantly, also include low birth weight if you develop a mental disorder during pregnancy. Again, health risk behavior, physical illness, reduced life expectancy of 7 to 25 years, mostly from physical illness, self-harm and suicide. The majority of suicide is as a result of mental disorder. And then if we're looking at the broader impacts, again, we're highlighting across education, work, including burnout, financial impacts, violence, both perpetration and victimization, homelessness, stigma discrimination, social, and of course, a huge impact on quality of life and well-being. Next slide, please. And if we're looking at health risk behavior, I just wanted to highlight, you know, the huge impact, for instance, on smoking. So smoking is responsible for 11.5% of global deaths, but in England, 42% of adult tobacco consumption is by people with mental disorder. So again, mental disorder is a very important driver of a range of health risk behaviours which are very relevant for population public health approaches. Next slide, please. This slide just highlights the loss of life expectancy, loss of the number of years of reduced life expectancy for different types of mental disorder. So you can see that it's not just an issue for people with schizophrenia, but across the range of the spectrum of different mental disorder, it has a huge impact on loss of life. Next slide, please. And then moving on to mental well-being, there's been a lot of work done in Thailand on well-being promotion. One of the challenges is there are different definitions which are important because we need to know the definitions do determine obviously what we measure and the interventions we implement. Martin Seligman's done quite a lot on the different constituents of well-being. And again, if we're thinking about the different constituents, then that will have implications for what we measure. As we know, pleasure is important, but limited. And interestingly, orientation to meaning and engagement predicts mental well-being, but orientation to pleasure does not. And I think probably most of us know that. But again, if we're thinking about a sustainable promotion of mental well-being across populations, given the impacts of mental well-being, which I'll highlight in the next slide, that's important. So next slide, please. So what are the impacts of mental well-being? And again, just to emphasize, meta-analysis level, systematic review level data highlights these impacts, the health benefits on reduction and prevention of mental disorder, suicide, health risk behavior, but also improved recovery from physical illness and reduced healthcare utilization, but also reduced mortality. And then similar, as we're looking at the impacts of mental disorder, we're looking across a broad range of areas. Mental well-being has impacts on educational outcomes, employment outcomes, including reduced burnout, social relationships, reduced antisocial behavior, and resilience. And next slide, please. Of course, well-being and mental disorder, they interrelate. They're interdependent. Our mental well-being protects us from mental disorder, but if we have mental disorder, it reduces our mental well-being. And certainly in England, the largest single group with poor well-being are those with mental disorder. So you can see there's an interrelationship between those two, and that's important if we're thinking about who we focus interventions to promote mental well-being for. Next slide, please. So looking at risk and protective factors is important if we're thinking about how we prevent mental disorder from arising, promote mental well-being, or promote recovery in those with mental disorder or poor mental well-being. Next slide, please. And I guess what's really helpful is the evidence base that exists that we know predict mental disorder and well-being. And a public health approach really is very interested in these wider determinants. If we think about cardiovascular disease, of course, we're interested in treating a myocardial infarction or a stroke when it comes in. But it really goes hand in hand with a more upstream approach to address risk factors to prevent a large proportion of those events happening. And a public health approach looks at the size of the impact of different factors, but also the proportion of the population affected. But interestingly, for mental disorder, because most of it arises so early in the life course, we're really very interested in those risk factors during pregnancy and early childhood, adolescence. And similarly, mental disorder during childhood is also a risk factor for adult mental disorder. Next slide, please. Inequality is a key it's a kind of like a cause of a cause in terms of risk factor. It's a risk factor that underlies many other risk factors. And so if we're thinking about sustainably reducing mental disorder, a very important thing to address. Of course, mental disorder then results in a whole range of inequalities. And so we have this cycle. So we're also interested in how we prevent those associated inequalities from arising. Next slide, please. I've just highlighted some of the risk factors for childhood mental disorder here, but I will highlight particular risk factors relevant to COVID shortly. But just really wanted to sort of highlight pregnancy is important, inequality, as I've said, socioeconomic and parental, as well as child adversity. But I think what's important here is that when we're looking at the evidence, there's very impressive evidence for each of these risk factors. And we shouldn't be overwhelmed as mental health professionals because we're actually thinking about different agencies addressing each of these risk factors. Next slide, please. Child adversity accounts for 30% of adult disorder. And you know, the global prevalence of child adversity is incredible. So half of all children have experienced emotional, physical, or sexual violence in the previous year. So if we're thinking about, first of all, the impact of that risk factor, but then the prevalence of it, again, it really stands out. Next slide, please. And then risk factors during adulthood. Again, we're looking at a range of risk factors, which really would be the responsibility of different agencies. But you know, just to highlight there, sort of, I guess, going down towards the lower area, a third in terms of violence, a third of women experience lifetime physical or sexual intimate partner violence, or non-intimate partner violence, sexual violence. And again, if we're thinking about COVID, we can see that some of these risk factors will be particularly being impacted by COVID. Next slide, please. Similarly, a range of protective factors for mental well-being. And suffice to say, again, if we're looking down that and thinking about ourselves, what are the important risk factors that actually influence our well-being? Some of these we can immediately recognise, but the importance is to really appreciate the fantastic level of evidence for some of these, which gives us even an odds ratio with narrow confidence intervals about the impact of those. And again, that has relevance for how we think about not only addressing current levels of mental ill health within our populations, but also future planning. Next slide, please. Particular groups are disproportionately affected by mental disorder. And that's really because risk factors congregate in those groups, and that is usually mediated by social disadvantage. And the reason for identifying those groups is that they disproportionately benefit from both treatment but more upstream approaches. And we need to be thinking about this idea of proportionate universalism, so that we're focusing more on these higher risk groups to prevent a widening of inequalities. Next slide, please. I've just highlighted some of the groups at high risk, and you can see that obviously some are the same in childhood and adolescence and adulthood. But again, it will be different in different countries. But I think again the importance is to acknowledge these groups, also to think about how we can target effectively interventions for both treatment and more upstream. Next slide, please. So if we're going on to the risk factors for COVID, there's a tremendous overlap. So next slide, please. We're thinking about demographics. So certain age groups, you know, higher in men, certain ethnic groups. There's certainly in UK, there's been a real the lower socioeconomic groups have disproportionately been impacted. people with pre-existing physical health conditions and obesity, people who smoke. So when you're looking at particularly people with pre-existing physical health conditions, obesity, smoking, mental disorder, those are disproportionately congregated in those groups. People with disability, including mental ill health, 60% of COVID deaths in England. So you can see this disproportionate impact on people with disability. Certain occupational groups, so patient-facing, healthcare or resident-facing social care roles in the UK, 6 times higher rates of COVID infection. And similarly, place of work and in the UK, care homes have been particularly disproportionately affected. Next slide, please. And so the mental health impacts of COVID. Next slide, please. What I wanted to highlight was really across population, across health professionals, the impact of COVID infection itself, the impact of quarantine, and then the impact on mental health services. Next slide, please. So across the population, again, I've just highlighted a couple of a systematic review and meta-analysis here, but highlighted the prevalence of depression and anxiety. And a UK longitudinal survey sort of highlighting that, you know, we've had an increase of significant levels of mental distress in the population from 19% to 27%, and then a doubling of depression. Suicide, certainly we know that previous pandemics have been associated with suicide, and certainly in UK, suicidal ideation increased during the COVID pandemic. Although certainly reports at the moment suggest there's either no rise or a fall in suicide. That's from country reports, although certainly the situation is less clear in low-income countries. So there's a little bit of uncertainty about that. But certainly, if we look at the impact of previous pandemics, then it's very significant. Next slide, please. The mental impacts of pandemics on health professionals, and again, we've got very good high-level evidence about the impacts on healthcare worker prevalence of depression and anxiety, which was actually interestingly similar for the general population in this review and meta-analysis by Luo and colleagues. And then you can see that the second half of the slide, they're really highlighting the impact of pandemics. A fantastic publication which highlighted the raised levels of mental disorder in healthcare workers, which isn't surprising. And we look at the levels of post-traumatic features, psychological distress, burnout. Immediately, what's kind of the alarm bells are highlighting, we need to be making sure that we look after our workforce. Next slide, please. And similarly, in terms of healthcare workers in contact with patients affected by COVID, again, you can see the level of increased stress and distress. However, so the psychological impact of SARS, for instance, similarly on healthcare workers, you can see that there are certain risk factors that actually mediated that risk. So again, very helpful if we're thinking about planning to protect our workforce. Next slide, please. And then essentially, why is that? And the mental impacts of COVID are really due to the effect on risk factors that I highlighted earlier. So if we're thinking about socioeconomic, the huge impact on socioeconomic inequalities, poverty, the World Bank recently estimated COVID was going to push 150 million people into extreme poverty, the impacts of loss of employment, workplace closure, debt, recession. And food insecurity is another key issue, certainly globally before COVID, and then the impact of COVID on food insecurity, which is a risk factor for mental disorder. And similarly, child adversity, which I highlighted earlier, a lot of evidence highlighting that actually that has been exacerbated by COVID for various reasons. And so again, of great concern. Next slide, please. The other risk factors impacted by COVID, you can see here I've highlighted, but sufficient to say that, you know, it's the impact of COVID on a range of risk factors for mental disorder and poor mental well-being. There's never been quite such a severe impact all at once. Next slide, please. And then if we're looking separately, the mental health impact of COVID, if we do get infection. So again, meta-analysis level data highlighting COVID associated with increased risk of mental disorder. But we need to think also about the increased risk of COVID infection in people with mental disorders who are at higher risk of infection. And then similarly, the increased mortality associated with COVID in people with mental disorder. And then the mental impacts of quarantine, certainly in countries that have quarantined, certainly those are very significant as well in terms of isolation, resulting in a range of psychological effects. Next slide, please. And then the effects of COVID on mental health services. So there was this, some of you may have seen this recent WHO publication, which was a survey of 130 countries, which outlined the level of disruption to critical mental health services. And over 60% of countries reported disruption. But just highlighting, I guess, that the levels of disruption reported, and obviously it's a relatively, so it's just a helpful, indicator of the impact, but also highlighting helpfully the reasons for disruption. And that included insufficient number or redeployment of health workers from mental health to other areas, use of mental health facilities as COVID quarantine or treatment facilities, insufficient PPE, and a lack of resource, essentially, or funding. Next slide, please. So, the public mental health challenges of COVID. Obviously, one of the challenges is to prevent what we would anticipate to be an increased prevalence of mental disorder and reduction in mental well-being, to particularly protect people with mental disorder from COVID and associated impacts, given their increased vulnerability, but also to protect the mental health of groups disproportionately affected. And I've highlighted those, but obviously including people with mental disorder, but also health professionals and carers. But again, this is, again, coming back to higher risk groups. We need to be thinking about that and anticipating and planning. Next slide, please. So coming to public mental health interventions. Next slide, please. What's fantastic news is that there are a range of cost-effective interventions across the life course to prevent mental disorder from arising in the first place, to intervene early for mental disorder, and then to prevent relapse of mental disorder and all the associated impacts that I've highlighted. But also interventions to promote well-being at different levels, and also interventions to promote resilience. And importantly, a bit like treating cardiovascular disease or addressing that area, it's not just about treatment, which will not sustainably reduce, for instance, cardiac myocardial infarctions or strokes. We need to be thinking in combination with more upstream approaches. Next slide, please. Interventions for different levels of prevention and promotion are provided by a range of agencies, which on the one hand make things more complex, but on the other hand, actually different agencies have different roles for different risk factors or different areas. So the key thing is coordination. Next slide, please. So if we're thinking about mental disorder prevention, first of all, next slide, please. We're looking at how we address risk factors as we would do for some area like cardiovascular disease, so addressing socioeconomic inequalities, parental factors, particularly important. A meta-analysis highlighted that treatment of parental mental disorder reduced offspring mental disorder by 40%. I've highlighted other interventions. Again, all of these have huge weights of evidence behind them. Intervening early for child mental disorder, addressing child adversity, particularly given it's responsible for over almost a third of adult mental disorder. Preventing violence, again, is another, again, area with stacks of evidence. Next slide, please. And then thinking about settings-based approaches in preschool, schools, addressing issues such as social isolation, early treatment of physical illness, which is a risk factor for mental illness, addressing a range of health risk behavior, Environmental factors, including actions to prevent and address pandemics, as well as other areas associated with other risk factors associated with increased mental disorder. And then suicide prevention, again, something highlighted in this event, and certainly improved coverage of mental disorder treatment, restricting access to lethal means. Again, excellent evidence for school-based awareness programs, brief intervention contact, CBT for self-harm, and more generous unemployment protection during recession. Again, good evidence for that. Next slide, please. Workplace-based primary prevention, important, particularly for health professionals. And I've highlighted in the top half of the slide, again, meta-analysis level evidence for different types of interventions for prevention of work-related mental disorder, stress, and burnout. And obviously, Thailand has a strong meditation tradition, and interestingly, a lot of fantastic studies done on that, including online mindfulness programs. And for health professionals, again, a range of interventions, including during COVID, done by certainly by Kisley was I found very helpful. I work in a full-time as a psychiatrist, but I found some of these things particularly helpful for my team and colleagues. And I think when we're thinking around how we address burnout and stress both during COVID and outside, I think when we look at some of these interventions I've highlighted and their impacts, I think that it's really important we're looking at the evidence and then thinking, how does it apply to our teams? Next slide, please. And then secondary mental disorder prevention. Again, the fantastic news is we have the evidence, including for lower middle income countries. We know that early identification and intervention is best. A stitch in time saves 9, we say in the UK. But we're also looking at how we address at an early stage associated impacts such as health risk behaviour. And I guess looking at the fact that half of lifetime mental disorder arises before adulthood, if we're thinking early, we need to be thinking adolescence is a key opportunity. We're thinking about COVID also in terms of early intervention in those with mental disorder. And of course, we're looking at various actions that include isolation of patients and staff with symptoms, testing, treatment and support, and of course, tracing, quarantine and testing of contacts. Next slide, please. And then tertiary mental disorder prevention. We're looking at obviously the implementation of effective treatment to ideally prevent relapse. We're looking at addressing health risk behaviours, including smoking, physical ill health, socioeconomic impacts, stigma discrimination, higher rates of suicide, and again to emphasise the very strong evidence for intervention in those areas. Next slide, please. Community prevention of COVID-19 in people with mental disorder. And again, I've just highlighted some of the things that we've been doing here, obviously, and most places are doing, but certainly screening prior to entry to a healthcare setting, physical distancing, PPE, also reducing the frequency of face-to-face contact. Certainly in our services, we've really kind of moved to telephone and video communication as a main way of interaction. We've been reducing the contact between people having to come into particular community mental health settings, reducing the frequency of depots, reducing the frequency of monthly clozapine blood monitoring, for instance. We've also been giving pneumococcal vaccination, and similarly looking at how we effectively reduce transmission for anyone with suspected or confirmed infection. Next slide, please. And then again, similar ways of addressing of prevention of COVID in people with mental disorder as inpatients. And again, I think these things many people are doing already, but I think particularly initially, obviously this hit us, and I think a public health approach often perhaps isn't thought of in secondary mental health care as psychiatrists, mental health professionals. Perhaps the majority of us aren't really thinking at a population approach, but obviously is critical for addressing COVID. Next slide, please. And then similarly, a range of interventions to promote well-being and resilience. And if we're thinking about COVID, this is obviously very appropriate and important. I've highlighted the different levels of prevention here. But I think just to say that wellbeing promotion also results in prevention of mental disorder and stress, which of course is important at any time. Next slide, please. If we're thinking about, just giving you an indication or just summarizing the fantastic evidence, again, the evidence is I wasn't aware of it until sitting down and going through it, but there's a wealth available. And I've just split it up into different stages of the life course here. And you can see if you're going through these different types of intervention, some of them would make sense, particularly when we're thinking about, the majority of mental disorder arising during adolescence, by adolescence. A range of evidence-based interventions to promote well-being, for instance, during adulthood. And you can see more broadly, just going down to the bottom there, meditation, mindfulness, interestingly, meta-analysis on compassion and forgiveness. And you think, well, who would do that? And again, it raises interesting questions about values held by societies, cultures, and often these can kind of go hand in hand much more easily for particular cultures. Next slide, please. Next slide, please. Thank you. And then working well, again, relevant to anyone in employment, sort of increased control, flexible working, training, and I've highlighted there mindfulness interventions, including online. And then across older people, similarly, the interventions for older people are similar to the living well interventions on the previous slide. But again, just to emphasize, very good evidence base for these interventions. Next slide, please. Similarly, resilience promotion. So school-based interventions, work-based programs, particularly for groups at higher risk of stress. And I've highlighted here, health professionals could be supported and prepared for both demands and psychological impacts before, during, and after events, such as COVID, to minimize risks and enhance resilience. So again, this is very relevant to now. Next slide, please. Mental well-being promotion and recovery. So for people who are experiencing a mental disorder, well-being promotion is very relevant. And again, I've just highlighted a few areas that I've just picked out because of the evidence base for them. So again, just need to be thinking slightly broadly around how we promote well-being in this group. Next slide, please. Economics is very important. And of course you think, well, look at all these interventions. How are we going to pay for them? Next slide, please. So we've got all these interventions. They work. They're the right thing to do if we're thinking about reducing the suffering and the impacts highlighted. But also many of the interventions result in economic savings, even in the short term. And there's an economic cost of not providing those interventions. However, the overall savings, the economic savings, is related to how well we cover the population who would benefit. And this can be a helpful driver for implementation, but also this therefore is a key part of sustainable economic development for any country. Next slide, please. So the figures in red here are from a piece of work done by the Department of Health in 2011, which estimated the net economic savings for these interventions for each pound spent. So these are the savings that accrue after you've paid for your intervention. So immediately what stands out is, wow, what amazing returns. And again, if we think about people who do the stock market or something like that, you can immediately see that this is actually an incredible investment. And these are actually conservative savings done by the London School of Economics. Next slide, please. I'll come back to that in a moment, the economics, but just in terms of public mental health policy development, next slide, please. Certainly public mental health has really has been prominently featured in the 2013 WHO Mental Health Action Plan, and then the UN Sustainable Development Goals. But also recently, the World Psychiatric Association made public mental health a key part of the 2020 to 2023 action plan. And I'm the lead for the Public Mental Health Working Group for WPA on this. And it's very exciting that WPA has really taken public mental health as a central feature of its action plan for the next 3 years. Next slide, please. However, the key thing is to look at the population coverage. And again, we're really dependent on coverage if we're going to get population impact. But unfortunately, only a minority of people with mental disorder receive any treatment globally, which is far less in lower middle income countries. There's even less access to interventions to prevent associated impacts, and virtually negligible implementation of interventions to address risk factors, which I've highlighted earlier. And this results in a broad range of preventable impacts, human suffering, and huge economic costs. It also represents a systematic contravention of the right to health and lost human potential. And during COVID, this implementation gap is being amplified. Next slide, please. So there are various causes of this gap. I mean, I think number one is the lack of knowledge about the size, impact, and cost of the gap. And I've highlighted here that, that only 46% of countries regularly compile mental health service activity data. There's a lack of information about the national impacts and associated economic benefits of improved coverage, a lack of public mental health knowledge and training, a lack of mental health policy in 28% of countries, but also a lack of implementation of policy, a lack of use of evidence in population health policies or programs, or by key decision makers everywhere, basically. And there's also a lack of transparent policy decisions about what is an acceptable level of coverage for these different interventions we know work and save money. Next slide, please. I think importantly, there's a lack of resource. So we're looking at at least a fifth of global disease burden due to mental disorder. But WHO found when it published its last mental health atlas, less than 2% of general government health expenditure was on mental health. And mental health received only 1% of developmental assistance. And there seems to be a lack of political will or understanding by those who allocate resources if we're looking at this mismatch. And as I just highlighted this issue earlier around COVID response in terms of mental health and psychosocial support, only 17% of countries had additional funding to cover these activities. And that's on top of this issue that I've highlighted above. And then there are specific causes of the treatment gap, and I won't go into it now just for time, but nevertheless, obviously very important if we're going to try and reduce that gap. Next slide, please. So actions to address the gap. There are 11 actions here. Suffice to say that, again, if we were able to actually act on these actions, then there would be massive impacts. Next slide, please. The first thing is really to assess what is the level of unmet need. And that's first required at a national level. And that includes taking account of issues like COVID, which, as Dr. Haslina said, isn't going away immediately, and there will be ongoing impacts. So we need to be thinking about that going forward. And I've just highlighted, I guess, the different areas of that public mental health needs assessment. Next slide, please. The second area, the second action is public mental health practice, which is looking, first of all, at the size, impact and cost of the current and anticipated public mental health intervention unmet need. And then looking also at the estimated impact and associated economic benefits of improved coverage, because of course it comes back to investment. We're looking then at the use of that needs assessment to inform policy and strategy, including across different sectors, because as you saw earlier from the slide, these impacts occur across different sectors. Then we use that needs assessment to think about transparently what is an acceptable level of provision and required resource. We communicate to different agencies and wider population. And I think this communication is critical, this transparency. And then we plan for commissioning, we operationalize, and then we coordinate between agencies. We then implement at a population level, and then we evaluate. And an important evaluation includes not just the outcomes of the intervention, but the coverage, including for those groups at high risk that I mentioned earlier. Next slide, please. Estimation of economic savings from scale implementation is really important. And I did a piece in The Lancet a couple of years ago with Professor Martin Knapp from the London School of Economics. And the figures here you can see just from 6 interventions. These would be the net savings if everyone in England who would benefit received these different interventions. And again, it's just an example to highlight, also sort of giving timeframes for when and where these savings would accrue, just to highlight the huge economic savings from improved implementation. And so everyone's a winner. It's obviously you're improving population mental health and you're saving money at the same time. Next slide, please. Training is critical. If we again come back to the public mental health or mental disorder accounting for at least 1/5 of global disease burden, we need appropriate training to a range of different professionals and trainees in different areas. And it's not just within health, it's a broader issue. And I think online training is particularly important. I just wanted to, in my reference list at the end, there is a reference for an online training module that I did for Health Education England on public mental health. And again, it's done in 40 minutes. It's using graphics and stuff, but it just gives an example of how online training can really give people very quickly. They don't need to be going on long courses. It can give people the basics so that they're really able to move on. Next slide, please. Other ways include improved population knowledge about mental health, including related to COVID. And Dr. Haslina highlighted, this actually the important role of media. Informational and internet-based interventions improve literacy, interestingly, but they actually have a very limited effect on help seeking. And there's quite a lot of interesting research going on into why that is. But targeted interventions, for instance, in the workplace, are much more effective in terms of both improving literacy and improving help seeking. The 5th area is settings-based approaches. So if we think about targeting particular settings, we can actually reach a very large proportion of the population in one place. And we can also deliver more than one intervention to that, if you like, captive audience. And so therefore, I think at a stroke, we're able to perhaps even think about both treatment, how we target treatment, for instance, schools or workplaces, but also at the same time, how you promote well-being, prevent mental disorder. Integrated approaches is the 6th area, and that's facilitated by this needs assessment, because what happens with the needs assessment is we see immediately what work is being done by who and where. And when we look again to those slides at the beginning, which were slightly detailed but important because they highlight the broad impacts of mental disorder across sectors. And these interventions are being delivered by a range of organizations across sectors. So I think there's again a really great opportunity for much more integrated working, including at policy level, between different sectors, between different policy areas to facilitate that integration. Next slide, please. Digital technology, again, Dr. Haslina highlighted. The evidence for internet and phone delivered public mental health interventions, including in low and middle income countries, very impressive, and can also deliver training. Interestingly, again, I came across with that WHO report that obviously high income countries using telemedicine and teletherapy to bridge gaps, but lower in lower income countries. However, there's a tremendous opportunity there, I think, to actually increase delivery. The eighth area is maximizing existing resources. So again, the evidence for self-help, task shifting from a more highly trained individual to a less trained individual, and thinking about how we can support improved concordance is really important. Other areas for suggestions are moving expenditure from large hospitals, which WHO highlighted was where most of mental health funding goes, particularly in low middle income countries, to more community, more local and community-based services. Next slide, please. Particular interventions, and again, in the report that I did last year, really highlighted the following interventions, which I think are real big opportunities. Certainly the first, to address socioeconomic inequalities. If we're thinking that they underlie so many other risk factors for mental disorder and poor mental well-being, and also how that COVID is really going to be disproportionately affecting many of those. Again, really important to think about constructively how that's done. I know the UNDP, for instance, was suggesting that debt that countries owe to the World Bank should instead be used to, for instance, provide a basic wage to the very poor, which would prevent, for instance, having to go and increase their risk of COVID. Parenting interventions, again, it's first line recommended intervention for the majority of mental disorder, but it also prevents a range of impacts and also promotes well-being and behavior both amongst children and their parents, and can be delivered digitally. Addressing parental mental disorder, I highlighted earlier, child adversity, and also increasing physical activity, which improves mental health across the life course. And again, some of these areas have been challenges for public health. How do we enable behavior change? But again, a real opportunity. Next slide, please. And then just this is the penultimate slide. So another great opportunity to support improved implementation is the use of existing legislation. So legislation such as rights legislation protect children, adolescents. We think about, how does that work? How can that promote well-being? How can we apply that? I mentioned rights, but the right to health includes the right to mental health and evidence-based interventions, both to treat, but also prevent and promote. And again, this can be an important mechanism for advocacy to improve the coverage of these interventions we know work and which have very broad impacts. And I think the last area is a really key one. We have all these evidence-based interventions, and yet the implementation is really poor. And there's something about what are the reasons for this implementation failure, and how can we actually improve the implementation of these wonderful interventions that actually have such impressive impacts. Next slide, please. So to summarize, mental disorder and poor well-being have large impacts across different sectors, which are due to increase because of COVID. There are effective interventions to treat mental disorder, prevent associated impacts, prevent mental disorder from arising and promote well-being. But the implementation failure is resulting in preventable suffering, broad impacts, and associated economic costs. And this implementation failure also represents a breach of the right to health. The implementation gap is also widening as a result of COVID. However, the gap can be addressed in several ways, which result in broad impacts and achievement of policy objectives across different sectors. And also, the improved implementation results in economic savings, even in the short term, which can be estimated in different countries. And so public mental health practice is therefore an important part of sustainable economic development and recovery from recession such as is occurring due to COVID. Improved implementation will mitigate COVID-associated mental health impacts, which are otherwise going to occur. Public mental health should also be an integrated part of the response to COVID. Next slide, please. These are just a few of the references. The third, I think the fourth one from the bottom is the e-learning program that are highlighted. So again, I know there are questions at the end, but I'm happy to be emailed for any further for any other queries after that. So many thanks. Sorry, it's been a bit of a rush through, but it's a key opportunity, I think, to highlight some of the opportunities that this approach offers. Thank you. Thanks a lot.
Thank you very much, Dr. Campion. That was a great presentation. I think the one thing that really came out of that for me was this important link between physical, mental health, and prevention. And we know the only way that we're going to tackle all these diseases that are affecting populations today is by early intervention. We will have time for questions at the end, and just also to let you know, we will be sending out the slides via a link on the conference website after this session. I'd like to now move to Dr. Burin, who's the Director of the Bureau of Mental Health Service Administration at the Department of Mental Health in Thailand, who's going to talk about the psychosocial consequences and challenges from COVID-19 outbreak and through a case study of the work in Thailand. So I'd like to invite Dr. Burin to speak. Thank you.
Hello. Good afternoon, everyone. Yeah, I'm Dr. Burin. I'm a representative from the Department of Mental Health. So I think we have little time left. So I might present using some 20 to 25 minutes. So this will give colleagues for having a discussion or whatever about their questions. So my topic is about the consequences on psychosocial parts and the challenges from the COVID-19 pandemic outbreak in Thailand. So the scope of presentation, could you give a slide? Yeah. Okay, could you turn the page? Okay, the scope of presentation that I'm about to presentation is about the situation of COVID-19 pandemic in Thailand, what we learned about the psychosocial impact from COVID-19 pandemic. I mean that this COVID-19 crisis is very huge one, and it has a ongoing characteristics, which means it's ups and downs. So it has some different phases on the different psychosocial impact phases. So the challenges and intervention for the mental health service in the country. And then we move on to the new normal mindset and mental health system, and suggestion and further chance. So next slide, please. Yes, this is a situation from COVID-19 pandemic from January to October 2020. So this currently, right now we have accumulative positive cases for COVID-19 about 3,880 accumulatively, and we have recovered, a lot of people recovered, and we have 60 dead. So I have to say one thing which is different from the other countries or other speakers countries is that Thailand may be a little bit fortunate about we have only one phase, only one break of infections, and then after that it can be controlled. But although we have control, we have a lot of fears about getting infected again. So many Thai people has a lot of mental health consequences from that. So this is another challenges that we have to face. This is a timeline for the infection. We began with the infection outside country from China at the first phases on January. At that moment, until on the March, we have more and more infection coming. So we have a widespread local infection from the super spreading infection in our country for 3 or 4 opportunities like that. And then after that, we have to lock down our countries. That is the first phase begins. After that, we are going from March to May. After May, we have no local infection, but we still have an infection outside country because we set up about the state quarantine here in Thailand. So everyone who has to come from abroad has to be in the quarantine setting from our government for 14 days. So what happens is that people got quarantined a lot in the state quarantine or some quarantine settings, and they have a lot of psychosocial consequences like that we need to do something for them. And then we prepare for the local infection. That is what the topics that we are going to talk about. The next pages, please. I can divide the psychosocial impact of Thai population towards the pandemic to 2 phases. The first phase is that the beginning of the outbreak and the lockdown on March to May 2020, due to a lot of cases at that moment, we have increasing. We found that the behavior of Thai people has been changed through many platforms. Like there are increased numbers of hotline calls concerning COVID-19 issues, both physically and mentally. But it always ends up in fear of contacting and fear of oneself getting another loved ones or relatives to be infected by them. So there are lots of increased numbers of hotline calls at that moment. On the hotline data registry of Thailand, around 41.9% reported increasing 1 to 3 hours to search for the COVID-19 information online. And most of them has been on the both true and false information. So that makes them alert and very alarmed at that moment, and then try to search more and more, comparing to only 1 hour before. 80 to 90% reported trying to increase self-help care, like wearing masks, maintain the distancing, and refraining from the public places. So at the moment, I can show you some stress and burnout at that moment in Thai population from the rapid survey of the Department of Mental Health during the COVID-19. And the stress level correlated with fear from the local and widespread local infection at that phases. And then stress level is found higher in health professionals and people at risk of contacting with COVID-19. You can see that next slides. So there may be in Thai languages, sorry for that, but this happens that the mental health hotline statistics increasing at that time of the outbreaks from March to June. At the moment, there are lots of hotline calls concerning about the stress and their fear of having contacted with the pandemic COVID-19 at the moment. Next slide, please. The trend of telephone consultation is very obvious on the March to May. And then the decrease after having not found much numbers of the COVID-19 infection and then decreasing. So you can see that around that lots of female, 64% comparing to the male, 44%. Next slide, please. So at the moment, we try to think that if there are the increasing activities, we'll find out about some stress or some alarm reaction from them. So we do the scope of rapid mental health survey at that moment. On the March to April, May to June, and then July to September, we have done 9 rounds of the rapid mental health survey at that moment. And next slide, please. You can see that the stress level, according to the timeline of the rapid survey 1, 2, and 3, comparing that, we can find that if on the moment of lockdown, there are increasing stress levels. The red and the yellow means that they have a severe and very severe stress level at that moment. by the assessment tools. The population is the same too, but the public health personnel concerned and have a lot of stress level more than the Thai population. Next slide, please. The burnout, yes, burnout, you can see from the burnout assessment in helper, we have both of them complain about emotional fatigue at work, and it's getting more and more after there are lots of cases, and poor self-perception of achievement of taking care of their patients, and then poor relationship and detachment from the relationship around their works. So there are lots of them, they got more stressful as they're taking care from the times have been, they have to take care a lot of patients at the moment. Next slide, please. Burnout, you can see that the burnout increasing at the times, but on May, after we can control infection, the burnout has been down from the health professionals. So you can see that I think the burnout from the work burden is up to the workloads at that moment. And what we have done on our health helpers is that we have counseling lines. We collaborate with other organizations, have counseling lines, which is separated from the other hotlines because they want some privacy. And then we refer them to the normal service if they had a lot of stressful and after they have some depression. Next slide, please. So the second phase is on the psychosocial impact post-lockdown and few local infection at the moment on June and July 2020. Less stressful than lockdown period at the moment, but most of Thai people reported concern from the social environment adjusting, like adjusting to the distancing from routine life and public place safety, deep concern about the lockdown effect, increased cost of self-care tools. They are worried about their incomes, the cost of using the self-care tools such as masks and the sanitation wash, and they have a fear of inadequate income and unable to meet family or people they love. And the most reported concern was the economic factor. At the moment, there was some no income from some people, and then some people were unemployed. This is the most concern on the second phases. After the lockdown has been dispatching and it's going to be finished, still the income and the economic factors played a part a lot. Next slide, please. You can see that this is a concern from the increased cost of self-protection and worried about the inadequate or no income, especially the normal population, the general population, not the helpers. And they're worried about not receiving the compensation money for make a living. So this is another concern. This caused them still stress as well. Next pages, please. The concern about not being to meet friends and family, and concern about vulnerable family members, and concern about not able to hang out with friends. There's still some concern of them after post-lockdown period. Next slide, please. This is very interesting about stressful about being unemployed. So they live on the uncertainty about unemployed or being unemployed, or maybe they don't have any jobs to do. So this is the second things on that phases. So we try to, next slide, please. We try to assess, another one is that we try to predict about the suicide rate of Thai population. This is the normal suicide rate per 100,000 population using our database on Thailand. So this is an estimate of suicide rate. It's going to be a little bit increased on the 2018 and next slide, please. Okay, so this year you can see on the green signs that people is 20% increased on March. I mean 3 months after the pandemic. So still on the March of each year, comparing, we have in this year, there are lots of increasing people committed suicide. So that is, this is another point that we have to be aware on the the affecting of the COVID-19 on the indirect effect on people. Next slide, please. We try to set the scenarios of the trend of suicide rate in 2020. On the worst case scenarios, that means persisting lockdowns. At the moment, we still don't know about the lockdowns, how long would it go. So we try to figure out about 8.8 per 100,000 populations in Thai people. Right now, I think the lockdown period at the scenario A is not possible now. So it's coming into the B or C. So the B is the most possible. So that's why we set the KPI on the suicide rates that we have to set down from the 8.8 per 100,000 populations. Yeah. Next slide, please. So comparing with this, the concern, we compare the 5 common factors contributing to suicide in Thai population. This year, the economic factors increasing. So that means that we have to be aware of the economic factors about unemployment, and we have to do something with that. Next slide, please. So you can see that this year, comparing to the 2018 to 2019, economic factors going up on 3.5 points, and another factors are going to minus. So economic factors play a part a lot. How do we do with that? Is the psychosocial response challenges. So next slide, please. The first phase that we try to do is that we set up about the reaction of people. We think that the reaction of people towards the COVID-19 pandemic at the first phase is the irrational, emotional, and behavioral responses about fear, anxiety, anger, and rage. So that means that we have to do the challenges on how to correct them to be the rational, emotional, behavioral responses. So we coined the terms, and we find that we have 5 levels of factors that have to be implemented through the promotion and prevention strategies for us. That means safety, calm, hope, efficiency, and then connectedness. Next slide, please. So this is conceptual framework of the coronavirus on 2020. It begins here until next year. So what we have done on this plan is that we done 2 strategies. On the first strategies is that we try to reduce the impacts from the mental health in terms of stress, depression, suicide, and burnout. And the other one is that we have to strengthen the mental immunity for them to live with the COVID-19. So the first thing is that we do something like active screening, active surveillance, and then we have active counseling for them. And a lot of intervention has been implemented on this in terms of doing this. If the people has been has some illness, so we turn them into the intervention on the step care. The second thing is that strengthening. It needs a lot of promotion and prevention strategies, which I will talk to you later. Next slide, please. Right now we have 4 groups that we have been survey, active screening, surveillance, and counseling. So the first is that the people or general community which has economic injuries. We try to think about this, and then we added this, and in terms of the survey and active screening, surveillance, and counseling. The second thing is that the vulnerable groups like elderly and people who has physical disabilities and the mental disabilities, also with a mental illness, to have an intervention on this too. The third group is that quarantine or infected person, COVID-19, because there has a lot of stigma. And the fourth group is that the medical personnel working on the COVID-19, that means the health helpers. So we found that I'm going to give you the next slide. So I will give you the timeline of the prevalence of stress, depression, burnout, and suicide in Thai population. You can see the the both phases. The first phase is that the phase of the local the infection. There are some local infection and it has been locked down. So this is quite high in terms of stress and burnout at that moment. But we still don't see much of the depression and suicide at that moment until everything has been cleared on the first phase. The depression and suicide is beginning to compiling up, rolling up a little bit, and then it turns out to be stable. It's not going down on depression and suicide. So that means that we have to do something like to continue about the monitoring about the depression and suicide in Thai population in the second phases, and find something like the factors that they're concerned most, or found some vulnerable groups to take care of, like the people who has economic injury, unemployed, and no income at all. Next slide, please. So what we found, what we have been doing this with the challenges, we try to do things like the promotion and prevention strategies. We put something like the media and technology, like the 3out. This is a look, listen, link. That means the psychological first aids. And to handle the COVID-19, we try to implement into many forms like infographics, videos, and the sample, and something like dramatic plays with that, so that people will know about how to take care of themselves using the look, listen, link. And the other thing is that we try to put something like the immunity, like durable, determine, and defeat. They can do it by themselves because a lot of people are very weak at that moment. They cannot control their lives. So this is the strength factors that they have. Next slide, please. This is the slides that are very important because we try to, sorry because it's in Thai, but most of them, to summarize, is that the people who is in the group of quarantine setting and people who is in the group of the infection along with their relatives has the first highest and the second highest on the issues of stress and depression. So this is what we have to monitoring on the people with quarantine. Next slide, please. What we have done to reduce the impact on mental health is that we do the step of COVID-19 mental health care. We use the 3 steps, but combining with the mental health literacy apps to make it easier to access to the online. And then after that, if they want to ask for help, they can use the online platform and self-application for this is online programs for things like the hotline calls and then the other video calls. And then if there's still some, they have some problems, we do the telecounseling with people or the specific mental health counseling and engage with the other organization as well. It's not only Department of Mental Health, but the hotlines organization. If they want to meet in person or we have something like more illness, we do the early psychosocial intervention through people, which means that we have MCAT outreach team. MCAT is emphasizing from the mental health care assessment and treatment team. And then after that, if they still have some problems, we will deal with the specialist service in the mental health hospital. So this is the step care of the COVID-19 mental health care at that moment in terms of protecting people, and it's according to the phases of infection as well. Next slide, please. There are lots of mental health needs at that moment. So collaboration between multi-sectoral factors is very important for us to find people in the community and engage them to the help in terms of mental health, like collaboration between mental health, Ministry of Interior and Ministry of Public Health to integration people to take care of the vulnerable groups in the community. in the community. And then it joined us with the health team. Next slide, please. So summarize of intervention that we give at the moment is most of them have a psychoeducation and they get better. After that, we have a psychological first aid. We have a teleconsultation using, and then some of them have to be in the crisis counseling. I think it's not much needed, the hospital psychiatrists, but then they need some people to give them a counseling and monitoring them. Next slide, please. So most of them some of them has to be follow up, about 6% not to follow up because they can get better by the community. Very few of them has to be referred into the hospital. Next slide, please. This is the lesson, the mental health impact. The other thing is that prepare for the further outbreak. That means strengthening their immunity, especially the mental health immunity. We have a mental vaccine. I think this is for resilience, tools for resilience for people, but we call that a mental vaccine. That means that something to put in to them and then they get resilience at the moment. Second thing is that how to make people, because this is a very long disaster, long crisis. We don't know when to stop. So they had the need to live with it, with the new normal mindset. So we have established a new normal mindset program. And then after that, for the people who has been in the service, especially in the mental health hospital and the health hospital, we have to do something like new normal service. Next slide. This is a family vaccine. We do third things is that the first thing is that individual resilience. That means the resilient program. The second thing is that we found that the family factors are very important. So we use something like family vaccine program, which has 3 factors like the positivity, the collaboration, and the flexibility of the family that can integrate together as a family resilience. And we have something like the campaign and promoting the community and the family as the best practice, and then we get it into the media. Next slide, please. This is community vaccine towards the community resilience. We use the 4 factors and the 2 has to be used. The 4 factors of the community vaccine means that the hope, the safety, how to get the safety, and the other one is that climb, how to make the mental health climb, how to get them hope, and destigmatization about the COVID-19. Use 2 things like community efficacy and the community network and relationships. So if we put together onto this, we can have some community vaccine which is promoting to the community resilience after COVID-19. Next is that new normal mindset, how to get people to live with a new normal mindset that reduce their sufferings and maybe have them more happy with their own balance. So we have 4 balance, like the mindfulness factors, the learning factors, the sufficiency factors, and then we have a sharing factors. So new normal mindset has to be implemented now for people in the community and put on into the media of training people or making them understand about the new normal mindset, how to live with the COVID-19, which will stay with us for a longer period of time. Next step is that the outbreak event, we still have some local outbreak events. This is another one, make a lot of people panic. So the outbreak event in Rayong, or maybe many provinces now, we have to do how to prepare them for not to be much on social panic and using some help ready for them. Okay, next slide, please. What we learned about things on the COVID-19 and mental health effects is that COVID-19 has a character of prolonged, ongoing crisis, ups and downs, never know when to stop. it has both direct and indirect effects on mental health and many dimensions, like a multidimensional on the economic and social context. So we need to understand not only the stress and the depression and the suicide, but we need to understand the social part and the multiple domains of people, how that they have stress on the economic and social context as well to implement the intervention of mental health. The needs for psychosocial help is very vast, so resulting on multi-sectoral help and digital and new normal approach. It is the right time to alert your policymaker. I think this is a crisis. Crisis means both. We have a threat, we have an opportunities. So the opportunity is that how to alert your policymaker to be aware of mental health in terms of not only their pathology finding, but how to make them strength. And the strength make people productive and more productive. Preparedness for the mental health strength in the next outbreak is very important, as well as the case finding and intervention in terms of pathology. So we need to look at both ways, like promotive and preventive comes to the intervention and treatment. So this is what I'm going to recap on this learning. So I think this is important quote from our Department of Mental Health. You say that health is life. Yes, you cannot survive without health, but mental health is happy life, and happy life make them productive. So the Thai society can go on with the people not to be mentally ill. So I think this is the summarization of this session. Thank you.
Thank you very much, Dr. Burin. That was a great presentation. I particularly like that quote at the end, health is life and mental health is a happy life. And I was particularly struck by the comments you made in your presentation around mental health immunity and the idea of a mental health vaccine, which I think is super important as countries, not only particularly like those of us in the West, which are still going through a second wave of COVID, but how will we prepare the populations for the future. Before we open up to questions, because we have a few minutes left for questions, I just want to sort of just pull together some of the strands from the various talks, because there was a lot of commonalities across all the countries, what we're seeing. And really what we need to look at is a kind of like a whole system approach to tackling both physical and mental health, with a real focus on prevention and early intervention. And I think, all the speakers at some point have referred to the role of policymakers. And I think one of the things that policymakers don't do very well is to learn from the past. And I think one thing that we do need to do with this current pandemic is learn from it. And that may well be looking at how we readjust our health services, particularly for the long term, and particularly, as Dr. Burin pointed out, around the economic consequences. And this referencing what Dr. Campion said around the importance of public mental health, how we really draw together the mental and physical health, and we put new emphasis on that. So I'd like to open up for questions. You can either put them in the chat or ask them for those of you in a room. However, we did have a question quite early on for Dr. Haslina. There was somebody asked how many COVID patients can be accommodated at your hospital. So I wonder if Dr. Haslina could just answer that.
Okay, so in our hospital, we can accommodate up to, what we have is 130 beds, but if there is need, we can go up to 228 beds. So we've got quite a amount of beds. That is only in Hospital Burmai, but we have more beds in other facilities as well. So that's the amount of bed that we have. 130 total beds, but we can go up to 228 beds.
Great, thanks very much. I just want to ask Dr. Campion a quick question. You made several references to policymakers, and I just wonder, how do you think we can really use, going back to the point I made a few minutes ago, about how can we learn from this experience and embed it into the policy process so we can draw together so the physical and mental health aspects and really ensure that we build resilience within our populations?
Yeah, I mean, I think it's. I think your point about learning from previous experiences is really important. And again, when we look at the literature, I think there's so much wealth in terms of evidence. So I think one of the things that it can often happen is that, and I include myself as a policymaker here, is you start in policy and you start from the beginning, and you don't perhaps look at what's gone on previously, even within your own department. So I think that's a first step. And I think the second area is then looking at the evidence base, because certainly I was the public mental health evidence lead at the UK's Department of Health for 3 years, and that was 10 years ago. But since then, the evidence base has exploded. And so that's a challenge for policymakers, but I think they need assistance with bringing all of the evidence together. What's worked both in interventions, but also in terms of implementation, scale implementation, to effectively address whatever the challenge is, whether it be COVID or whether it be another public mental health challenge. So I think it's a very important question. I think, interestingly, I highlighted implementation research as a key area. And I think that very much links in with your point, Dr. Exeter, about learning. And so that includes learning from implementation failure and success from policy.
Yes, I agree. I mean, as being involved in policy myself, I always think that history is one of our most important lessons in policy making. I just, in the last few minutes, we don't have any more questions. I just wanted to see if there was any final comments from any of the speakers or any of the panel before we wrap up. No, in that case, well, I'd like to thank Dr. Campion, Dr. Hasselino, and Dr. Burin for their excellent presentations. As I said, copies of the slides will be available on the conference website, which you'll be able to log in and download from the site. There's also an evaluation form, which we'd be grateful if you could complete as well. I'd like to thank the Department of Mental Health and my colleagues at the British Embassy in Bangkok for organising this really, really interesting session. And I look forward to the next one, which will be on the 14th of January 2021, where we'll be discussing digital mental health. And we'll be having some interesting evidence coming forward for that that we're working on at the moment. And finally, I'd like to thank you all for your participation, for those of us in the West this morning, and for those of you in Southeast Asia this afternoon. So I'd like to wish you all a very good rest of your day, and goodbye.
Bye.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you, everyone.
Thank you.
Thank you.
Thank you, everyone.
Thank you. Thank you very much.
Thank you. Thank you, everyone. Thank you.
Thank you, everybody.
Thank you.
Thank you.
Hope to see you in Xi'an.
Thank you, everyone.
Good. Oops.
Okay, for all participants, please evaluate form. You will get certificate after you do evaluate for us. Please scan QR code on the screen and link it. You can see the linkage on the chat board. Thank you so much for everyone.
Dah isi dah? Tak. Ni mental challenges evaluation ni. Ayo, so lazy. Tak apa, nanti kita dapat. Ayo, I don't know. Role in conference participant lah.
Yeah.
Stupid lah this one. Public health technical officer.
Off it.
Jahat kau. Ni, others ke tak payah? Public health technical officer.
Yeah.
Oh, betul lah. Aku tanya ni kejap. Dia kata apa lah?